Okay, well, first, thank you for the opportunity to speak here. Thank you also for the emphasis on diagnostics. It's something I believe is very important, and I think Rosanna did an amazing job of giving us an insight in what is going to happen and how it should, and I think will develop. We'll find a way. So I would like to talk about tuberculosis, and as you know, tuberculosis diagnostics is complicated. Tuberculosis diagnosis treatment is long, and with the issue of drug resistance, it's becoming increasingly complicated, although there are some very exciting drugs coming along, and we should make sure we use those as effectively as possible. Now, this is something I took from the MSF infographic, and this is some data from, I think it's 2011, but it makes the point that although there's a lot of tuberculosis, there's a lot of tuberculosis diagnosed, and there's a lot of MDR, tuberculosis diagnosed, it's only scratching the surface, and the number of patients who really get accurate, correct diagnosis of multi-drug resistant TB, when you estimate how many cases there really are, there's something really bad going on here. You see this syringe is only half full, some very low percentages, so there's really a case to make. And last year I gave a talk here where I emphasized that, but this year, for the purposes of time, I'm going to move on. But I'd like to emphasize that although there's been massive progress in tuberculosis diagnostics, the management of patients of a lot of patients is still suboptimal. So what do patients really care about? Patients care about that their symptoms are removed. And in order to do that, you have to differentiate symptoms from disease. This is a very old idea. There were much work on this. Seems to be from the 10th century that this first started, and there's the very nice little diagrams of what was happening to the patient over the days with these little symbols, and there are even keys to break these symbols if you're interested. But when we give a patient antibiotic, we're attacking the presumed cause of the symptoms. So if our diagnostic is correct, we're attacking the real cause of our symptoms, and will be successful in the treatment. So the patient's primary concern is, will the drugs work? So if we've got a correct diagnosis, there's still things going on there. There's different patients will metabolize drugs differently, and we know some of the dosing for the TB drugs is absolutely not optimal, and that's being addressed by some very key work with this high-dose rifampicin, etc. There's also the drug supply. If we give the right dose of drugs, but they're too old, they've been stored too hot, they've been switched for fake medicines, all this really happens, then we won't get a good response. And then the final point, which has also received, and probably received the most attention in this sort of environment, is the issue of antibiotic resistance. And if the bacterium has managed to acquire mutations which make it totally insensitive to some or all of the drugs which we're giving for the multi-drug therapy, then we're not going to get a response. And in many settings, it may be that the third issue is the most important, but we cannot forget the other two. And if we do a PCR which looks for drug resistance, of course, we're only addressing issue 3. So TB management, TB control has been a very, very stable operation until recently, where FIND, we heard from FIND have done a sterling work in pulling efforts together and moving things forward, and that really has happened. But as I said, TB treatment is at least 6 months long, can be up to 2 years, and we want to monitor what is going on with those patients. We don't want to just empirically, randomly go ahead regardless, then we get lots of treatment failures. And the classical way of monitoring tuberculosis treatment is microscopy. So we look for patients going from microscopy positive to microscopy negative, and backed up by, if you can do it, culture. So you can culture the organisms, you can see if the organisms are still viable, if they're still viable, you can do susceptibility testing. And this is hugely challenging. This is hugely challenging for Western labs anyway. And if you're trying to do this in a high burden setting where you have relatively constrained, limited infrastructure, you have big problems. We've heard about the Cepheid device, we've heard about the GeneXpert. Microscopy is becoming rather absurd for treatment monitoring now. A large proportion of patients, because we're diagnosing with PCR, are going to start PCR negative, so they're not going to switch from being microscopy negative, so they're not going to switch from being microscopy positive to microscopy negative. And as I said, culture is slow and complex and has proved a barrier to the expansion of MDR treatment. The WHO recommends that you have access to full DST for first, second line drugs, and this is very challenging for laboratories to do. Whole genome sequencing holds promise, absolutely, and it's moving extremely rapidly, and for some drugs, the whole genome sequencing is going to rival the culture, probably because the culture is more prone to, it's more complicated, so it's more prone to issues going wrong. And of course, culture is also only a proxy for activity of the drugs in the patient. People say, oh, if it's sensitive in vitro, it must work in the patient. That's not really true. I mean, those of you who know pyrazinamide is not active under standard culture, but it is active in the patient. So it's not true that DST is the answer to everything. So what I'm making here, you probably worked it out already, is a case for some simple, practical way of monitoring treatment. And another example is that there is a lot of effort to make standardized multi-drug resistance TB therapy. There is this very exciting Bangladesh regimen, which at least in the initial trials has performed very well. And this is often quoted as a 9-month regimen, but if you look, it's in inverted commas in the title of the paper. And this is because actually treatment monitoring is essential for this regimen. The regimen is actually 9 to 15 months, depending on when you become culture or smear negative. So you must have 3 negative results, and then you continue, which means the minimum duration of therapy is 9 months, and the maximum is 15 if you follow the protocol. And this is relatively short. I mean, it sounds extremely long if you think about malaria treatment or something, or other bacteria, but for TB, this is quite short. And we also see the same thing with, there are efforts to shorten the treatment even more. There were all these Remux trial, the Oflatub trial, the Rifacoin trial, all quite disappointing actually. When with the 4-month regimens, most of the patients did quite well, but the regimens were actually inferior to the standard regimen, and that's because you get relapses after the therapy, and that's because a certain proportion of patients, too high a proportion of patients, are not getting enough treatment. And if we knew who those people were, we could stop the people who were cured at 4 months, and we could continue the people who require longer treatment. And this is the also call from FINE, WHO, and others, this test of cure. And this is very challenging, but I hope to give you some of our ideas on where we move forward. And I think it's a field where we can move forward. So this is something we've been talking about for the past 4 years, I believe. So monitoring the effect of tuberculosis treatment from the perspective of, well, we started out looking for anything, looking for bits of lyse bacteria circulating, spike in antibodies in relation to starting therapy, or the cytokine, immunomarkers, host markers. And after some initial studies with multiplex assays, with the Luminex assay, examination of the literature with a very nice detailed biomarker studies, we focused in on the host response, and we did some much more detailed work on the host response. And what we're trying to do is measure the patient's response to early bacterial killing. That's basically in a nutshell. And so if the drugs that have been prescribed are being taken by the patient, are getting to the bacteria and they're working, we want to see if something's happening. And we initially validated this in a mouse study with an infection placebo-controlled trial. And this was quite important because we wanted to convince ourselves that we're not just looking at the drugs doing things to the host flora, because of course you're taking relatively antibiotics with relatively broad spectrum, and there's a possibility that indeed we could be measuring the active antibiotics entering the patient, but not the effect on the mycobacteria. So this mouse study convinced us that that was not the case. So we went forward with a study to validate this concept in some patients from Nepal and Nigeria, and I presented these results last year. And we zoom in on this CXCL10, IP10 protein, which gave us a very good sensitivity and specificity, not to diagnose tuberculosis, but to detect the cohort of patients who are receiving effective therapy, or who are not receiving effective therapy. You can switch it around. So that would give you the possibility to say, these patients are doing well, keep doing it, or this group of patients, let's leverage what laboratory diagnostic medical infrastructure we have, and let's sort out and let's work out what's going on. Maybe we need to think of a differential diagnosis. Maybe we need to look at MDR, XDR. And this was the data from that study. And the interesting thing, so they're split up between HIV positive, HIV negative, smear positive, smear negative, culture positive, culture negative. The right-hand bar is very interesting. This is day 0. We measure the IP10 at day 0 and day 7. And you can see for the patients which were subsequently found to be culture negative and started smear negative, very little happened to their IP10. It started low, it didn't go down, and it stayed the same. Whereas if you look on the left-hand side, we have the HIV negatives, the HIV positives, smear positives, culture positives, and most of these patients have a nice drop. There's a couple that go up, and we believe in a large proportion of cases this is due to drug resistance slowing down or stopping the effect of therapy. Okay, that's our data, you can believe it or not. And I mean, it's always nice to have confirmation in the literature. If lots of groups see the same thing, then maybe we're really onto something. This was a paper that was published just later in the year from a group in China, and they also measured IP10 levels. This is at 0 weeks, 2 weeks, and 8 weeks, and they correlated with the microscopy conversion. And then you get a 2-week and an 8-week group for microscopy conversion on the right-hand side. And you see, indeed, again, you see these drops in IP10, which do seem to correlate with the standard measure of treatment response. So there's something going on. It's independent confirmation. And we have also Morten Roel's group from Denmark, who are also looking into this thing. And again, you see these weeks on the right-hand side, week 0, week 2, week 8, week 24. And they also see this correlation with this marker with a treatment response. So this becomes more and more exciting. The more biomarkers are always very dangerous. You see the cancer biomarkers, which are published with lots of trumpets sounding and then fade away afterwards. So for TB to have this marker, which is not specific for TB, it's a host marker of disease, but we are adding specificity by looking at this response correlated with starting treatment. And this comes back to the slide Professor Rosanna Peeling presented, where you have the microscopy is the most believable if you can see the organism, and then you have the ELISAs for the host response, which actually has relatively low specificity. We are trying to play a trick here. So we are trying to say, but we can make something which is a little bit specific, really specific, by temporally correlating it with an intervention in the patient. How do we move forward? So we move forwards by based on this data which we've collected and others have collected, we've made some classifiers. So we've said, look, we have to be able to say something about an individual patient. These lines are individual patients, but a lot of what is said is really rather in the population, the IP10 goes down. So that's not what you want. You want to be able to say something about an individual patient, and we made these classifiers. So we've said if you get a decrease in IP10 of greater than 300 picograms per mil between day 0 and day 7, then your patient is responding to therapy. If this is not the case, if it stays high, then you maybe do have TB, but maybe it's drug resistant. You ought to do some laboratory workup. If it's below, if it starts off very low and it stays very low, maybe you ought to think about a differential diagnosis, but definitely you ought to go back to the patient and do some sort of workup. So we got some money from FIND to look at this idea in a cohort of patients in Mozambique, Maputo, all HIV positive patients, and we're going to perform a standard ELISA at day 0 and day 7 and day 60, but we will just classify on the day 0, day 7 levels, and we will correlate that with the bacterial and clinical response. So there's very detailed work being done in Mozambique to collect nice patient data. And we will store these samples as well, because these samples, okay, we are interested in this biomarker for this study, but there are lots of other groups working on other things, and it may be that somebody gets a better one. So this is the data from, I think it's the first 78, 79 patients from Mozambique. I was hoping we would have recruited all the 100 patients and done all the ELISAs, but as we're waiting to day 60, this data is still anonymized. But we've classified them into our 3 groups. So the left-hand side, you have the people who we say, based on 2 simple ELISA tests, have TB and are responding to therapy. We have a consider a differential diagnosis group in the middle, and we have a delayed response, consider a differential diagnosis, maybe look for drug resistance. So when this data is broken, I will either be very disappointed or very, very happy, but we promise to publish this. The quality of the journal might depend on the sensitivity and specificity of the day 0, day 7, but anyway. But this is actually looking very promising. They fall into 3 groups. There are interesting things going on. Fingers crossed. So we think this concept gives the potential for a near-patient TB assay that could be used to follow therapy to tuberculosis. So it could be used as a near-patient proxy for measuring drug levels, performing DST, checking that the patient is complying with the therapy. Of course, that would have to be backed up by some sort of laboratory infrastructure, but you would be able to leverage that infrastructure for the patients where things were going wrong. And it's already been mentioned today that there is a whole heap of ideas and activity going on making near-patient ELISA assays. We saw a mobile phone adapter. There is in Leiden University work on a device to automatically and quantitatively read lateral flow strips, using an upconverting phosphor system. So, and this has been recently part of an EDCTP2 funded project, which we heard about, EDCTP2 HOST-B2 we heard about yesterday. They are looking at host biomarkers to diagnose TB, but of course there's definite synergies between these two ideas. So if this pans out, I would be very interested to look at the kinetics of their host biomarkers, and I'm quite sure IP10 is one of their biomarkers. It's one of those that comes out again and again in tuberculosis. Yeah, we can think of non-lung infections. Of course, this is a host response, so it should work in maybe in children. That would be an extremely interesting study to do. If somebody knows how I can get that funded, please come to me after the talk. Yeah. Now, I would just like to end this talk by saying monitoring response to treatment is not really very original. Of course, this is what people have always been doing. This is what good clinicians do. And I mean, there is lots of data of these people, you know, they start therapy, they start to feel better, they get worse. You do an investigation, you find out what it is. And also, this is why people stop their therapy, because they take a few weeks of therapy, they feel a lot better, they feel better than they've felt for years. TB is a slow disease. And then they think, well, that was good. Modern medicine is superb. They've done their bit for me, and I'll go away. And of course, then they relapse, because we know you need this long therapy to eliminate the bacteria. So if we can collect this objective data of what is happening to the patient, I think we can give more patients access to observant, excellent medic. And that would be a good thing. And I think this is maybe an opportunity for many other things. And there are other people thinking about this. And I don't think it's been mentioned, but it was mentioned last year in this meeting. There is this concept of wearables and collection of data. And I do think maybe Rosanna was, I don't think she actually said wearables, but maybe I was panicking about my talk and I didn't hear it. But I mean, we're looking at host immune response. You can think if you could measure ambulatory temperature during the whole TB treatment or during the first 2 weeks, there's probably data in that as well. And that's just an idea I would like to throw out. But I mean, even relatively complicated ELISA would be a massive step forward if it correlates with treatment response. And we believe we're within grasping distance of that. So I know this is a very advanced meeting, so I would like to give you the opportunity to tweet something. So you can tweet IP10 is equivalent to CRP for TB, or you can say it might be, or you can say probably it isn't. But anyway, so that's my talk condensed into very few characters. And with that, I would like to say thank you very much for listening. Thank you for FIND for listening to our ideas and giving us some seed money to get this patient cohort collected. Frank Oberlins has been a great support. Dick Van Solingen has been a great support. And also, of course, the patients and the laboratory staff in Maputo who've really gone for this. And when we break the code, I hope it's very exciting. So I would like to say thank you very much for your attention, and I'm sorry I took up your coffee break, I think.